this is actually one of my favorite lectures. I love talking about this because this is the kind of stuff that happens all the time in blood bank. You get these discrepancies. And I'm saying all the time, usually they're really easy to deal with and easy to like handle and mess around with, but they do happen, and there's a lot of different things that can cause them. So the lecture is going to be about recognizing them. Hopefully, if you all saw something like this, you would say, oh, there's a problem, right? At this point, you should be able to recognize that we have problems. Resolving any serum problems and resolving the cell problems, because you have to look at it both directions. What's causing our problem? Is the patient cells or patient serum? And again, serum, plasma, interchangeable for our purposes. So, go back to lecture 2, 3, something like that, right? We talked about this. Results must match. Forward typing is an A, backward type is an A, it's an A. Forward type is a B, backward types, it's a B, etc. Your forward typing and your back typing must match. If they don't match, you're not going to get the right blood type at the end, and it's going to be a problem. Or if you just say, well, forward must be right, I can ignore the back. You can't do that. You have to be able to pay attention to the whole thing and figure out what's going on. So this is what is normal. This is what we're going to get. However, you get things like this. This guy's forward typing is a what? What's he back typing as?
O.
An O. What do we call him?
KF.
Nope. You can't call him anything until we figure out what it is, right? We have to troubleshoot and figure out what's causing the problem. This guy looks like a B forward, looks like an AB backwards. This guy looks like a B forward, A backwards. These are problems, and what we have to do before we can do anything is we have to figure it out. Now, in cases of emergency, we can give O-negative blood, like especially if we need blood right now, patient's bleeding out. But that's not going to be ideal because once you start giving O-negative blood, the blood type is going to get funky too because now they have two populations of blood cells in them if they weren't an O-negative to start with. So, it isn't enough to merely identify the discrepancy, but you must resolve it. So you can't say, yep, that doesn't work. Good luck, you can't get blood. We have to resolve it and figure out what's going on. If the discrepancy cannot be resolved, you must transfuse the O blood, like I just said. If it is on a donor, the donor bag does not get labeled until the discrepancy is taken care of. And even then, a lot of times those bags are never going to end up in our blood banks because if they are problematic with typing, and now we get them and they go to the hospital's not going to be able to type them, and it's going to put a log jam there also. So on donor units, usually they get pulled out for specialized testing of other sorts. So, steps to begin with resolving. First off, repeat the test. Okay, it could be a clerical problem, it could be a technical error. What happens if you have 3 patients and you take the plasma off of patient A and put it with patient B? Okay, the plasma, so you're typing the same patient, but actually it's 2 different patients, forward and reverse. Things like that can happen. Maybe it was something you didn't have your reagents in order, didn't have your tubes in the right order. Remember from day one I said all your tubes must always be in the right order all the way down? What happens if your A cells and B cells were flipped and you didn't catch it, and when you spun them, you put them back the right way, but you put the wrong cells in the wrong tubes? Things like that. First thing we always do, repeat the test. What's going on? Check the patient's history, age. Okay, very young, very old, they're going to likely not have the antibodies. Maybe you can have an issue with that. Diagnosis. There's certain diagnoses we're going to talk about in this lecture that could cause the problem. Certain diagnoses that it's like, oh, ding, 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 we got a winner here. That's what's causing our problem. Recent transfusions. Remember that guy on that video, 28 units of blood in the first 24 hours? What's his blood type these days? Well, not now, but like right after that, right? If he got, of that 28 units, if his first 10 units were an O-neg or an O, he's replaced his entire supply, right? So maybe he has a history of being an A, but now he's an O until all that blood dies off, 120 days of normal red cell lives. So it could be a while till we get a good typing on him. When you're looking at these reactions, the weakest one is going to be usually the one you're going to doubt. So find your weakest reaction, because you know that ABO typing are usually 3 and 4 pluses, right? Everybody should be getting 3 and 4 pluses on their forward and reverse typing most of the time. So if you only have a 1 or a 2, that's the one we're going to question. There are usually more problems with serum than with cells. So if you're kind of like wavering where to start, you can't figure it out, start with the serum, because that's a lot, we tend to have a lot more problems with serum. And then we're going to check the screening cell results. The screening cell results you all know are type O, right? So if it's positive, the antibody problem is probably outside the ABO. What happens, our donor A cells, what happens if they got an E and the patient has an anti-E? They could be reacting with the A even though they're a B, right? You know, there's things that could be going wrong with that. So if it's positive, if the antibody screen is positive, it's probably not an ABO problem. If the antibody screen is negative, it probably is an ABO problem. So, clerical errors, things that can go wrong. Recording incorrect results. Remember, we read one tube, write one tube. Read one tube, write one tube. The reason we do that is if I read 3 or 4 and they're in the wrong order in my hands, or I kind of get sloppy, I could put the wrong result in the wrong spot. Recording the results on the wrong patient. One patient per rack. I would say put the rack with those pieces of paper, right? So that as you're working, each paper is with its own rack. If you have piles and you're flipping through, you can very easily write the wrong results down. Recording the results in the wrong spot on the worksheet. I read my A cells, but I've recorded it in my B cell tube. Technical errors, mixing up patient wash cells of one patient with the serum of another. I talked about that. Failure to wash the patient red cells. If you don't wash them, those unbound antibodies are going to cause problems. Using too heavy of a cell suspension. Is that going to be a prozone or a post zone? Post zone. Too much antigen. Antigen excess. If I have too many cells, too much antigen. That will keep coming back. So don't forget pre-zone, post-zone, and zone of equivalence, okay? Failure to add the serum or reagent. This is why one of my rules is you put all your clear in first to make sure you put it in. All these things I've been hammering all semester, there's a reason for all of them, okay? I'm not just being picky. I mean, I am being picky, but it's all to protect the patient on the other side and to help you get in those habits. Quality assurance is what this is. It's quality assurance practices. It's quality practices that if you do them the same way every time, all the time, you know you never deviate. Adding the wrong reagent. Thankfully, we have color coding for our A and our B and our AHG. That helps. But there's a lot of very clear reagents. Our D and our PEG are both clear. Warming the test. You should never just randomly warm tests. And sometimes if it's you know, set it on the heat block, put things in heat block. You should only do that if you're actually running a full pre-warm. Under or over centrifugation. If you're supposed to centrifuge it for 15 seconds and you centrifuge it for 1.5 minutes, use 0.2 instead of 1, those cells are going to be so packed together that they're going to look chunky just because we push them together so much. Failure to recognize or detect weak results. Gotta be super careful you are not over shaking, especially when you're starting having weird results. Repeat it and shake even lighter because you might have shaken out a weaker result and missed something. Failure to recognize hemolysis. Remember lab 1? You shook out that 12th tube, it was hemolysis. The cells disappear, it went pink, and the supernatant wasn't pink before. You're always comparing it to the normal, how it was before you did it. But you've got to recognize hemolysis as a positive reaction.
I thought hemolysis was when it came out looking pink instead of clear with a button.
Yeah, well, yeah. So you could have hemolysis if it starts with a normal yellow plasma and you put it with the cells and then your supernatant is pink, even with a button, like the ones we did on 12, we got rid of the button completely. I wiped out that button. But even with a button, you have to recognize that, oh, the plasma's pink now, and it wasn't pink when I first put it in there. So that's what you have to make sure you recognize. Those slight hemolyses, something like that. I don't know how to say it. Slight hemolysis is a significant reaction, so you've got to make sure to recognize that. Misinterpreting small fibrin clots as agglutination. We saw a lot of that 2 weeks ago, right? Those weird, and you guys even recognize, they look weird. Something's off about this. And then these small fibrin clots in the plasma that the cells just kind of stick to. The nice thing, you get the stick, pull the stick out, use the stick, pull the little fibrin clot out. If it's gone, when you respin it, it won't come back. If it's agglutination, when you respin it, it's likely to come back. Contaminated reagents. You got to make sure your reagents aren't cloudy. This doesn't happen often, but it could, where you get bacterial contamination in your reagents, or you somehow like contaminate, you put them into the tubes and drop, and so they get blood on the reagents and then in the tubes. So you want to be really careful with contaminating of reagents. So some of the problems we're going to see with the serum/plasma. As I said, way more common to have problems with the serum plasma side because you're dealing with antibodies. And we all know that antibodies over your lifetime, you don't get many when, you're first born, you get your mom's antibodies, and then over time your antibodies go up. And then as you get older, your immune system shuts down a little bit and your antibodies aren't as good anymore again. They can manifest as an extra antibody present or an expected antibody missing. You can get both sides. If an extra antibody is present, you're going to check the screen cells. Okay? Because if the extra antibody is there and your screen cells are positive, it's probably one of those other antigens on the red cell. It's probably not that problem. So it's outside the ABO. If the screen cells are negative, now we're looking at something that probably is in the ABO. Problems we see, decreased immunoglobulin levels, like I said, infants and elderly in particular, people going through chemotherapy, bone marrow transplants, any sort of cancer treatments, any sort of immunosuppressive treatments, any of that kind of stuff, we're likely to see lower levels of immunoglobulins. Subgroups of A that are going to react with our anti-A1, passively transfused anti-A or anti-B or anti-A comma B. Passively transfused is when you're going to get like platelets of the same type. When we get to platelets, you'll see it's about 50 cc's, and they're in plasma, and they don't have to be type specific. So you're getting a handful of non-type specific plasma. So as an A patient, if I get B platelets, I'm getting a little bit of anti-A. So my back typing might show up as a 1 type with my A cells when I wouldn't expect it. Because I shouldn't, as an A patient, I shouldn't have any anti-A, but they just gave me a 50 ml bolus of anti-A. And so it's self-limiting, eventually it's going to go away, but it's going to cause a weak or a 1+ reaction for a period of time. Non-ABO IgM antibodies can cause the cold agglutinins or auto-Is. For example, everything agglutinates with big I, all adult cells, so we're going to have a problem. P, Lewis's, things like that, that could be on those red cells that we're testing. So our A cells and our B cells aren't just A antigens on the red cell, right? It's a red cell with A antigens and all those other blood group antigens. We try to put as few as we can on those red cells, but they can be there. We think that's what was happening last week with the A cells, because we were running the A cells, remember, all the way through like a panel, and they were all positive. We think those A cells had Duffy antigen on them, is what we think happened with that. So usually in the lab, you go back and you get a different A cell and you run it with a different one, and we just didn't have a different one to run. Rouleau, multiple myeloma in particular gets Rouleau, and Rouleau looks like agglutination. We'll show that up here in a few minutes. So let's look at some cases. There's some things going on. We have got expected antibody missing. So forward type, this looks like an A. Backwards type, it looks like an AB. We expected this to be positive, right? Because we assume two things. One, this is nice big 4+, so that's probably right. This is a completely negative, so that's probably right. More times than not, we have a problem with the serum than with the cells, and so we expect this one to be wrong. So, 39-year-old, no recent transfusion, diagnosis of AIDS. What do we know about AIDS? It's going to affect your immunoglobulins. So, we expect that maybe his anti-B is just missing or very low quantities of it. So because it's this, what we can do is we can actually enhance it by a cold incubation. ABO likes cold, right? Our IgMs like cold. So what we're going to do is we're going to take both. You don't take just the one you expect. You take both of the ones, the back typing, and you're going to incubate them at 4 degrees Celsius. There are instructions in your manual for how to do this. Follow the instructions of your facility. But you're going to incubate them both, because you can't just incubate one, because what if this one comes up too? That doesn't solve our problem. So you incubate them both at 4 degrees, and now, oh good, we end up getting a 2+ with our B cells. Forward types as an A, backward types as an A. We can now interpret this as an A. So we not only identified it, we've resolved it. Resolving is only if you actually get it to work out to a number somehow. Okay, so that's what we're looking for resolving. As I said, we're gonna run both of them because you want this one to stay negative. If this one does go positive, now you gotta look at what else is happening. So you can't just run one and hope it does what you want it to do. If both cells are expected to be positive in the back type, like in this situation, we expect this to be an O, so we expect both of them to be positive, then we actually have to run an auto control to have a negative, because what if something else caused these two to be positive? So you gotta run a third one that you know will stay negative. You always have to have one negative result to prove that everything worked the right way. If the control cell is positive, like I said here, so this was looked like an A forward, well now they're both positive. This discrepancy still has not been solved. We still don't have an answer. We expected this one to be positive, but now this one's causing us problems. So what we're gonna do is we're going to do it again, but instead of 4 degrees, we're going to incubate at room temperature for 30 minutes, and now we've got the negative A1 and the positive B, so now we've actually got our interpretation resolved. Missing antibodies we see in babies. That's why we don't even try to back-type newborns. They don't have antibodies yet. Immunosuppressed patients, anybody on any sort of, there's so many different things that cause immunosuppression. Bone marrow transplant recipients, they wipe out the entire immune system so that the body doesn't fight the bone marrow transplant and allows the bone marrow transplant to take over. So, now, unexpected typing in the back type. So, forward type looks like an A, backward type looks like an O. What are we going to call it? So in this situation, we always want to look at the weaker result and the serum. Those are the two things we're going to look at, and here it's the same one, so we expect this guy to be our problem. So we're going to check the screening cells. Screening cells are negative. Okay? So that's going to tell us that it's probably within the ABO system, because it's not on the screening cells. So likely it could be either a subgroup of A with anti-A1 or a passive ABO antibody. Those are the two things we think of when we see this very, very low 1+ with the A1 cells. So recent transfusions, none. 51-year-old pre-op arthroscopic surgery. So you gotta have some sort of scope done. No recent transfusion lets us know it's probably not some sort of passive ABO issue, because that's very self-limiting. A passive ABO issue, like I said, you get that bolus of 50 cc's of plasma, self-limiting, it's going to go away. That's not going to be our problem. Likely explanation is an anti-A1 in a patient with a subgroup of A. So, we've talked about this before. We did this a few weeks, several weeks ago now when we did our lectin typings. We're going to lectin type the patient to determine subgroup status. If it is positive, it's an A1, it's not a subgroup. If it is negative, it is some sort of a subgroup, most probably an A2. Why is it most probably an A2 subgroup?
People with A2 can develop anti-A1 antibody.
Yeah, but, whoops, I went too far back. Why isn't it one of the other subgroups though? Why is it most likely A2?
Not probable.
Not probable. It's just numbers, right? 80% of people that are A are A1s, 20% are A2s, and less than that, that's because of rounding, right? But less than 1% are all of the other subgroups together. So probability-wise, number-wise, probably going to be an A2.
What if they are? Because
If they are what? A different subgroup?
Yeah.
You still treat it as a subgroup. They don't get treated any differently if they react with the A2 cells. We know that they have anti-A1, or if they don't react, instead of A1 cells, we use A2 cells. If they don't react, we've resolved it. So A2 is just the most common one. If they're AS, they're going to look totally different yet too, though. So that one we'd be able to figure out. Okay, do that. Okay, next one, subgroup of an A with an anti-A1. If the patient is a subgroup, test the serum against A2 cells, that's what I was just saying. So instead of A1 cells here, we're gonna use A2 cells, it's negative, we can report it out. Instead of A1 cells, if patients developed an anti-A1, we just use the A2 cells. Because in the body, we don't care if it's an A1, A2. Do I have to worry about giving this patient A2 cells instead of A1? No. It's cold acting, it's not gonna be reactive at body temperature. We can go ahead and just give whatever unit of A is on the shelf and life is good. Okay, so now, unexpected reaction, back typing. So this is the same one we had before. So serum, weak reaction. Screen is negative, which means what? What? ABO, inside the ABO. So, recent transfusion, 25 red cells, 20 fresh frozen plasma, 3 apheresis platelets yesterday, 45-year-old aneurysm repair. That's always fun at 2 o'clock at night when you're the only one in blood bank. Okay, that happens. And they've gotten better with it, but we used to go through, we still can go through a lot of blood. But this is highlighted, apheresis platelets. That's our big ding, 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 right? So what type did they get? Red cells, all group A. Fresh frozen plasma, all group A. Platelets, 2 group A, 1 group O. So in this case, we're suspecting a passive anti-A or anti-AB from our group O platelets. Remember, you get that bolus with that little bit of plasma in it? So in this situation, we can do all of this. We're going to do a DAT. If positive, we're going to do an elute from the red cell and test against AB and O cells. Reactions with A and B, but not O, indicates an anti-AB from O platelets. Cannot resolve discrepancy. We'll have to transfuse group O blood. That's a lot, right? We're going to have to do all these things. Most of the time, instead of doing all these things, you're going to say, yep, they got platelets, give O blood. Okay? Most of the time, you're not going to have to do all this. Very, very seldom will anybody ask you to do all that because that's a lot of work. And the patient, we know what's causing it. Okay, now, same scenario up on top. 1 plus weakest reaction, serum, most likely the problem, but this time, our screen cell 1 is positive. What's that tell us?
Cold antibody? Yeah.
Cold antibody outside of the ABO. So, IH, Lewis, Immonen, or P are our main culprits for this, is what we're going to look for. History, recent transfusions, 2 red cells last week, 50-year-old below the knee amputation. That's what that stands for. So what we're going to do is we're going to do a pre-worm. We're going to pre-worm our back type. We pre-worm it, we get rid of it. It was a cold agglutinin, and we're good to go. We resolved it, now it looks like an A. It's resolved. Same thing up here, serum, 1 plus, probably our problem. Screen, they're both 1 plus. Recent transfusion, 3 red cells, 5 fresh frozen plasma last month. Usually those are going to be type specific. They should be. 68-year-old multiple myeloma. Do you guys remember anything about multiple myeloma? Did you guys talk about multiple myeloma in immunology? Okay, I thought you did. What do you guys remember about multiple myeloma?
At least a rouleau formation.
Rouleau. Multiple myeloma, rouleau. Keep that here because that's one of those things that will keep showing up in a lot of our classes because it causes a lot of problems in the lab with things, not only blood bank, but other areas. Hematology. When you start talking about it, it actually creates rouleau and causes problems with hematology, with reading of cells. It causes rouleau on your smears. Very common board type of a question about multiple myeloma and rouleau. High protein causes it to happen. So here's what agglutination looks like. Here's what our rouleau looks like. Can you really tell the difference? Not really. They're pretty similar. When you look under a microscope, when you're suspecting rouleau though, this is what agglutination looks like. These little clumps of cells. This is what rouleau looks like. Now, this is obviously more rouleau than this is agglutination, but you can see how they're stacked all together. That's rouleau. So, in this situation, we do a saline replacement technique. We take both tubes from the back typing, we centrifuge them to form the button. Instead of resuspending them, we're going to draw off the supernatant with the pipette, and then we're going to replace it with a drop of saline in each, or 2 drops of saline in each tube. Now when you resuspend the button, you don't have all those plasma proteins making that rouleau happen. So when you resuspend the button, the saline prevents that rouleau from happening. So now with the saline replacement, we got a 0 there. So forwards is an A, backs is an A. We've resolved it right there. True agglutination will still be there, but you won't actually have the rouleau. So problems with cell typing. Now this is the other side of it. Things we see with the cell problem. Mixed field agglutination, antigen deletion, cold agglutinins, and massively transfused patients. So mixed field agglutination doesn't actually cause a true discrepancy, but it really needs to be recognized. We have to decide what type of blood to transfuse. And if you're dealing with a mixed field, you're dealing with somebody who has their own blood plus donor blood. So you got 2 different blood populations in the body. When you have the 2 different blood populations in the body, now I've got 2 different blood populations in my tube. Seen as a slight or to strong agglutination among a sea of ungglutinated cells. So let's say I got a whole lot of O blood, and I'm a type A, and I got a whole lot of O, and then there's so much, let's say I'm 50-50 even, right? I got 6 units of O. If I go against my anti-A, half of my cells are going to be completely negative floating around, and half of my cells are going to have like a 3+ reaction, because they're going to be the A is reacting with the anti-A. So that's what we're looking at when we're looking at something like that. I talked about the dual cell populations. Should only be reported in tests involving patient cells, never plasma, because we're dealing with 2 cell populations. It doesn't matter with the plasma, it only matters with the cells. So here's classic situations. We're going to see cell typing of a group AB or AB newborn who's been transfused with O blood. Remember, intrauterine or newborns, we're going to give them O negative, very well washed blood, because we don't want them reacting with anything, so they're going to have a lot of O blood in their system. Cell of an AB or AB trauma victim who has received emergency transfusion of O negative blood, or any O, because right now, remember, we don't really always stick to the A negative, except in women of childbearing, so it could be an O positive sometimes. Cell typing of an AB or B surgical patient who had a massive transfusion and received non-type specific blood. This happens. How many Bs and ABs do we have on the shelf? Not a ton. And so if you have to have a massive transfusion, there's times we're going to have to give you non-type specific blood. Cell typing of an ABO unmatched bone marrow transplant recipient, cells from the old marrow and the new marrow are both present. So some cells are being produced are the A's and some are the O's, for example. So you have 2 different bone marrow populations.
Does that cause problems in the patient?
The patient will end up, what they do is major plasma exchanges to remove that plasma, and then you don't develop more antibodies. They try to kill those B cells that'll produce antibodies. So like, for example, I have anti-B because I'm an A, and if I suddenly got an O, well, if I had an O bone marrow, normally that would produce anti-A and anti-B, but it won't produce the anti-A because it still recognizes me as self. It would only be if I would get a B, and then that would be very rare because there aren't as many Bs out there, I suppose. So, loss of antigens, as we're looking at these guys, forward types is an O, backward types is an A. Something's going on there. So, normally we think serum, so it's either a problem here or it's a problem there. So, 53-year-old, recent transfusions, 15 platelets, bone marrow transplant, group O. So, it's just what we were just talking about. So, what's going on in his situation? ABO discrepancies are seen when the marrow of different ABO type patients are transplanted. They receive total body irradiation to decrease your antibody production. New marrow and grafts, new cell line gets generated. No corresponding antibody gets produced, but the tissues still do have the old ABO on the tissues. So the red cell transfusions should be compatible with old and new blood types. So, whoops, I'm gonna go back here. So what's happened is he got bone marrow transplant of group O, so now the cells are of group O, but he still has that old plasma hanging out. He's got those old cells producing anti-B. So similar situation, loss of cells, 53-15 platelets, CML in blast crisis. You guys haven't gotten to your abnormal, not abnormal heme, yeah, abnormal heme. Advanced heme, you start getting into abnormal stuff where you'll start learning about this. This is a leukemia. So CML affects chromosomes 9 and 22, and the ABO genes are on chromosome 9. This is one of those things, remember we talked about chromosome 9 way back when I talked about ABO? This is where it gets to be important. If you see a diagnosis of CML, you know it's going to affect your ABOs. Abnormal chromosome is likely to result in the loss of the gene. So you may see a microscopic population of some A cells floating around, but your new cells aren't going to necessarily have that. You can do absorption elution studies, you can do saliva testing, or you can just start transfusing O cells AB plasma, which most of us are going to do. Because even if you do all the elutions and everything, it's not necessarily going to prove anything. Okay, cells plus anti-A negative. Again, same problems that we had before. 16-year-old, 8 units of ONED red cells, MVA, motor vehicle accident. What's going on this one? We talked about it a little bit ago. Massive transfusion. He's got so many new cells in his body, his old cells are hiding out somewhere. So multiple transfused trauma victim, RH type was probably also going to be affected in this situation if they were an RH positive. Now most of the cells are probably going to be RH negative for a while. Most cells present are going to be our donor ONEG cells. We might examine it microscopically, because microscopically you might see small little clumps to be able to kind of figure out what's going on. At this point though, you're probably going to have to continue transfusing O blood until that population is totally gone. 120 days, a red cell lives. So it could be a while, but you're going to have to keep transfusing this O blood. If a female patient, especially O negative, hopefully at some point the blood usage slows down, and within a couple of months you can kind of convert back if they do need future blood of type specific. Cold agglutinins. Yikers. 36-year-old, no recent transfusion, mycoplasma pneumonia infection. What do we remember about mycoplasma pneumonia? Auto anti-I, big I. What do we remember about big I?
Everywhere.
Everywhere. Everybody has it. All of our cells have it. It's all over the place. So our typical pattern, this is typical for auto anti-I, everything's positive. The auto anti-I is going to coat the patient cells as the sample cools down, and all the cells are going to agglutinate. Anti-I reacts with all adult cells, including A and B cells, screen cells, everything. Results in agglutination in all tubes. So how do we fix it? We draw a new sample and we're going to keep it warm. We're going to use warm saline to wash those cells several times, make a 3% suspicion with warm saline. We're going to pre-warm our back typing, meaning we're going to take the 2 drops of plasma, put it in the heat block for each of those tubes and pre-warm it before we add the patient cells. Reagent manufacturers warn against pre-warming forward typing. So the anti-A and the anti-B reagents, they do not want to pre-warming because it could affect how they work. We are going to pre-warm the plasma before we do our back typing. So to fix it, we're going to do the pre-warm and all the 37-degree washes, keep everything warm along the way, and now we always end up at the control. If you don't do it, we always do it, but in this situation, if you don't do it in your lab, this is where you would add it, and you can see we interpreted it out then as a B. So conclusions, first thing, repeat the test. Check for technical and clerical issues, okay? That is going to be one of our biggest problems. It used to be even a bigger problem with mislabeling patients. That's why we are so picky when we teach you how to identify your patients, and we're always saying read the labels. I think I've talked about this, when you go into your blood drawn in a lab, how often do they put your labels down? Can you spell your last name? They're not even looking at your labels. It's just so out of habit, no one's paying attention. Drives me nuts. But you gotta make sure you're looking at that patient as they're spelling it. Make sure they are telling you who they are. Too many positives, we're gonna look for the weaker reaction. That's gonna be our one that we're gonna doubt. Use the results of screening cells. They're gonna help you. Is it in or outside of ABO? What are we looking at? Check the patient's age, diagnosis, and recent transfusion history. And if you can't resolve the discrepancy, transfuse group O red cells and AB plasma.